series here, and it gives me great pleasure to welcome Dave Pedowitz, a dear friend of mine who's an orthopedic surgeon in Philadelphia, talking about total ankle revision and salvage. You heard in session one how you do ankle replacements and ankle arthritis. Now you're going to learn about what happens when you have problems with these. And I want to thank Additive Orthopedics for sponsoring this session. Dave, it's all yours.
Thanks, Selene. Okay, so I want to start by thanking Additive Orthopedics and also the Parekh Family Foundation, who has been a real supporter of international education, specifically in foot and ankle, for a long time. And we really do appreciate that. And thanks for including us. All right, so total ankle revision and salvage. These are our disclosures. And we're going to start by introducing the panel. We'll have a case-based discussion and kind of go from there. So this is our foot and ankle group at the Rothman Institute. Tonight we have myself, Dave Pedowitz. We have Joe Daniel, one of my close friends and colleagues, as well as Brian Winters, Dan Fuchs, and Justin Tsai. Brian, Joe, Dan, and I are all in the Philadelphia area. Justin is in New York City. And just to give you a sort of an idea of where we are, here on the East Coast of the United States, we are in Philadelphia, which is generally thought to be about halfway between Washington, D.C. and New York City. And Justin is up in New York. Philadelphia, the sixth largest city in America, 1.6 million people. A nice place. That's a picture of our skyline. And we had the signing of the U.S. Constitution and the Declaration of Independence in Philadelphia, so it does have some significant historical significance for most Americans. And we are all at the Rothman Institute, so we're all partners. We're at the same practice. It was started in 1970 by Dr. Rothman. We have over 200 physicians in 40 offices in 4 states, with a bunch of different hospitals and surgical sites. We're team physicians for many professional teams. And in 2019, we did about almost 60,000 surgeries. So we have a lot of surgeries and a lot of experience. And so when you do lots of reconstructions, you end up seeing failures. And that's why I think we've put together a nice panel of people who can discuss some difficult cases. So total ankle revision. As we know, total ankle replacement is a challenging procedure. Revision total ankle replacement is even more challenging, and I would say because of things like bone loss and deformity and poor soft tissues. And revision is not always an option, so salvage comes into play. Okay, we have a bunch of implant options. The implant options in the United States, and we're getting to cases in a second. I just wanted to introduce some basics. The implant options in the United States are few. There's the Salto XT from Smith & Nephew, which was recently acquired from Integra. It has a flat cut talus. There are some variants of this available in Europe with stems that go into the subtalar joint. That's not available in the United States. There's the Salto XT Revision, which has a stem tibial implant and then a sloped talus. And then, of course, there's also the Envision by Wright Medical, which is a modular system, which is compatible with the InBone and Infinity components. Okay, that having been said, let's start with the case. Okay, so this is a 55-year-old female, 2 years status post of Salto. Brian, any thoughts? She has pain immediately.
I mean, the overall alignment looks okay, but I would want to see a full-length tibia film to see if there's any deformity.
Okay, no history of action. She has pain. So you're exactly right. So we got a full-length tibial film, and that's kind of what we got. Thoughts?
How far out is she, you said?
She's a few years. Mm-hmm. With isolated medial pain.
Mm-hmm. Any foot deformities that are contributing?
No, she thinks that she's got a total ankle that's just like kind of bothering her on the medial side. And she's tried orthotics, she's gone to therapy, she's had an injection. The injection helps.
Mhm. Well, it tells me that she's developing some medial gutter arthritis, and if this is left alone, likely have a high risk of early failure. So things should be addressed surgically.
So Justin, what are your thoughts about what the options are here?
Yeah, I mean, I agree. It looks like it mainly involves the gutter. I mean, I'd like to see it.
What was the failure here?
The
Sure, I mean, does it look loose? I mean,
It's not loose. Brian,
yeah, it might be a alignment.
exactly.
Yeah, it's basically the axis that the implant was put along the distal segment when it should have been if you were going to not do an osteotomy, for instance, should have been done in conjunction with the proximal segment, which probably had no deformity, I'm assuming.
Correct. So that's the X-ray that's the alignment that the original surgeon got on the initial X-ray and sort of went with it. And it's right if you only have a distal X-ray, right? But that's actually their mechanical alignment, which is, now in 13 degrees of varus. So Justin, what are your options? What are you thinking of if someone's saying, hey, I have pain here and it's bothering me? What can you do for them?
I mean, you could try maybe just go, if you wanted to go minimal, you could try to just go in and try to, clean out the medial gutter or align more distally. But obviously, I think for a more definitive revision, you have to consider a revision or consider a proximal realignment procedure.
Joe, what if you were going to do, if you were considering options here, are you considering a supravelar osteotomy, like a revision total ankle and keep the alignment the way it is?
Can you hear me okay, Dave?
Yeah.
I would keep the total ankle implant as it is. It's not loose. There's no evidence of infection. I would go more proximal and try to correct the axis proximal to that old fracture.
So you'd go above. So wait, you'd go above that old fracture?
No, I'd go within the fracture itself and align that fracture misalignment with the more proximal axis.
And how long? And how? So you would do an opening wedge osteotomy medially, or a closing wedge osteotomy laterally? Like how are you gonna do this?
I would probably do a closing wedge osteotomy laterally on that individual.
Okay, and would you osteotomize the fibula as well?
I would include that in my consent. Likely, yes.
Okay. Dan, are you leaning towards a supramalleolar osteotomy or revising the ankle?
No, I'd also agree with the osteotomy. The ankle placement itself looks good, but the deformity is uncorrected. So I think addressing that directly would be my preference.
All right, great, because that's not what I did. So revision is an option, right? You'd have to revise both components or do a supramalleolar osteotomy. So tibial revision is an option with poly exchange. Supramalleolar osteotomy. So I discussed that with her. That is a long procedure that's hard to heal. So it's okay, and I think it works. It's just a hard sell. So she wanted to see if we could go ahead with just a revision, and this is what I did. So basically what I did was I used a microsagittal saw, and I got this from one of my joint colleagues. The idea is basically cutting. So this is a well-fixed implant, right? So to take out a well-fixed implant, you don't want to add any bone loss. So I used the microsagittal saw to essentially trace around the implant. There's also, to make that hole for the post, there's also a curved osteotome. So I used that as well. And I was able to sort of use the inserter of the implant to actually just bring it out once I had made those cuts. And then what I did was I just sort of tilted it that little bit, right? And bone grafted. in that area. That created a defect. When I tilted the implant back, it created a bit of a defect, and I bone grafted that defect. And this is what I got. And I think that, I mean, look, that's nice and parallel to the fibula. I think it's reasonably well aligned to her mechanical axis. And the medial gutter is nicely opened up. And that's kind of the axis. So a mechanically well aligned implant. However, here, I'm going to just go back. If you did this, what would be your weight bearing status post-operatively, Brian?
I mean, with the bone graft, I would keep her non-weight bearing until you got some new interdigitation in the tibial tray. It sounds like it wasn't necessarily like a press fit there immediately, if I understood you correctly.
Yeah, exactly. So for how long? 2 weeks?
I'd probably do 4 to 6 weeks. I'd probably give it some time. What'd you use for graft? Was it structured? Was it like chips of some sort or cancellous?
I just use calcaneal autograft.
Mm-hmm. Yeah,
So,
I would be concerned about that subsiding, so I probably would err on the side of caution and protect them a little bit longer.
Dave?
Yeah.
I'd do a minimum of 6 to 8 on that.
Okay, probably reasonable. But no good deed goes unpunished. So she had a little bit of itching and discomfort around her knee afterwards. Okay. And we told her to come into the office. She didn't want to come in. She had some 3 weeks post-op of redness and itching at the tibial jig pin site, right? She refused to come back in. We gave her some PO antibiotics, and she got a total knee infection on the same side from a pin site infection, requiring a staged revision of her knee. So, look, I know that we all don't take surgery lightly. Patients sometimes do, but even when we try and minimize an intervention, it can sometimes end up being a much bigger deal than we expected it to be. And that was certainly the case here. Okay. Here's our second case. All right. So, Justin, what are your thoughts? 56-year-old police officer. She teaches at the police academy.
Yeah, looks like typical post-traumatic arthritis. It looks like she had a prior pilon fracture that I'm seeing hardware, so it probably was treated non-operatively. She's got some deformity posteriorly, some heterotopic bone anteriorly. It's tilted in not an unsurmountable amount of errors, probably about 5 degrees or so. Obviously we get a CT scan in this case, would want one.
Dan, anything else of interest on the x-rays?
I'm not sure what that ossification or calcification is anterior to the tibia. But I'd be interested to know more of the history, what the prior surgeries were. It looks like there's some type of staples.
Yeah, those are
vascular. Hear about flap. Looks like was this an open injury?
Yeah, it was. Yeah.
See what her soft tissue's like.
Yeah, so she's 10 years out from RIF of a trimal. She had removal of hardware. She had a skin graft posteriorly.
Dave?
Yeah.
Is she only tender at the ankle, or does she have some talar joint involvement?
Just ankle.
Okay.
So she's a heavy smoker. Will you do a reconstruction procedure on smokers, Joe?
Are you talking about total ankle arthroplasty?
So this is any surgery that's going to help this woman is going to be a big surgery, right? So yeah. I'm really talking about any of those surgeries, whether it's a cage, a total ankle, a fusion, whatever it is.
I would be more inclined to do an arthrodesis procedure in a smoker than a total ankle arthroplasty in an individual with soft tissue compromise, what appears to be anteriorly. Mm-hmm. But I would counsel this individual excessively with regards to potential complications and risk of amputation potentially.
Yeah, Justin, do you have specific thoughts about smokers and any procedure that would be helpful for this patient?
I don't have a hard stop. I don't get a nicotine level myself, but obviously, I have a conversation with the patient, just telling them, it's really, I really stress the point that, amputation is really a very real consequence or second life, if things don't go well because of the smoking, and usually they're okay with it and they stop smoking, or they say that they're not willing to, and then we don't do surgery.
Yeah, do you have a hard stop?
Yeah, I wouldn't do ankle fusion or an ankle replacement on someone until they stop smoking.
Yeah, I agree. That's my approach as well. I give them a month to stop smoking. They have to have nicotine levels separated by a month. They need nicotine levels when they want surgery, and then a month later they need to be 0. So in any event, she underwent a total ankle replacement. She stopped smoking. She was motivated to. She got the nicotine level. She stopped smoking. So she had a cadence total ankle replacement. I put a screw up the medial malleolus and seemed to do okay, except for this. So she had wound breakdown anteriorly at 3 weeks. I did have her see a plastic surgeon preoperatively just to assess like the anterior soft tissues. He thought it would be fine. So she had an acute infection, right? So she had a washout with a poly exchange and medial malleolar screws, but then she had this. So she got a flap and then 6 weeks of intravenous antibiotics. Okay. This is after the flap. So the flap was done essentially at the time that we revised her poly. So we just did a poly. She had an acute infection. We did a poly exchange, and she got a flap. Okay.
IV antibiotics, I would assume. Yes.
Yeah. So does anyone have a problem with that? So let me just go back to that. Okay. So she has wound breakdown anteriorly at 3 weeks. Okay. She has a draining wound at 3 weeks. Nothing before then. She has an acute infection. We do a washout, a poly exchange, and she gets a flap and IV antibiotics, right? So there's still an implant in there. Anyone have a problem with that, or is that okay? That's what I did, but does anyone have a problem with that?
This
That's
wound,
fine.
obviously this was deep, but is the implant directly beneath the tendon soft tissue there? Or is it covered by
it is,
there
but
a draining sinus?
No, there's no draining sinus, but again, I thought this was an acute infection, so
Yeah.
I took out the poly. The implant was, not
Right.
loose, but only 3 weeks old, so it's not like
Right.
it's ingrown, right? So
Yeah, I think in this case, I think you made the right decision. I would have done the same thing.
fine.
Trying to salvage.
Now at 4 months, she has a deep infection. She has
Yeah.
obvious loosening and pain. All right. So what I did was I lifted up the flap and I put in an antibiotic spacer. So now what are your options? Joe.
Well, there is literature to support leaving that spacer in, but I don't recommend that in a police officer. I would follow her clinically and serologically. My endpoint would be to do a cage on her and a retrograde tibial-talocalcaneal arthrodesis, now likely.
Dan.
I'd agree. Once you're confident the infection's cleared, revising it to a fusion with a rod and either custom cage or femoral head allograft.
Why not a revision total ankle?
Just personal preference.
What about you, Justin?
I agree. I think the only thing I'd add is that before we did the spacer, I think I would have had and you probably did, but had a real conversation with her about the possibility or even the option of a BKA, just in case a one-time operation to spare her future surgeries.
Hey, Dave.
Dave, can I ask you a question?
Yeah, go ahead.
Do you think that, I'm just asking, do you think that you may have missed the infection when you do poly exchange and cultures, et cetera? Would you?
How is it not? How is it conceivable that she didn't have a deep infection the whole time?
Understood.
Right?
So
I mean, like, clearly she did. I mean, you know, oftentimes we sort of lean towards what we want our patients to have as opposed to what they have. I think this was probably misguided, you know, unfounded optimism on my part in terms of what I thought I was addressing. Her symptoms, look, if you ran it by the books, yes, she had a wound that didn't look great, but only like a very short amount of time of symptoms. And when I went in there, you know, I just took out the poly, washed it out, and I was putting, a filet mignon on the front. So I felt like, you know, the blood supply would be good and it would heal nicely. But I think you're absolutely right that this was probably a deep-seated infection in the first place, and she probably should have had this procedure at the first take back.
So Dave, that brings up a question that I have received asking, for acute infections, is poly exchange appropriate, right? Or how do you know if poly exchange is enough or not?
So you don't. I mean, that's why there's an infection consensus meeting every year, because the hip and knee colleagues aren't able to always determine when there's an acute infection. I mean, when there's an infection that would do well with poly exchange and antibiotics, or one that requires both implants to be removed. There is data to support poly exchange and antibiotics. And that's why I did it. But I think, honestly, it's a balance of just clinical judgment, which was probably lacking a little bit in my treatment of this case initially. Joe, were you going to say something?
yeah, I was just going to comment to Dr. Parekh's question was, what you did is not wrong by any stretch, but I would have looked more, Dave, at this lady's surgical history and her social history, and it would have probably been more aggressive at that first time in, just going after it.
Yeah, so here's what I did. So I did the IND, I lifted up the medial flap, 6 weeks of IV antibiotics. Brian, would you consider a revision total ankle in this, or only a cage like the rest of the group?
I mean, obviously, if I was convinced that the infection was cleared after further workup, I think there's enough bone stock, I would probably change it out to more of an in-bone type of prosthesis to get more proximal fixation. You have the options, in particular with the Envision system, more broad-based support onto the talus, although you probably could get a flat top talus in there. But I wouldn't shy away from another ankle, but obviously have a good heart-to-heart with the patient that this cannot end up in the direction that she would want. How old is she again? In her 50s, I think.
It's like 48, like 50,
48.
50.
Yeah.
Early 50s.
So, also to have the discussion is that it may not be her last surgery, obviously, as well with the revisions. But I wouldn't, if I was convinced that this, the infection was overall cleared, I would consider it.
Fine. So here's what we did. Whoops, sorry. 1 week out. Sorry about that. Let me play here.
Or a Salto.
So I ended up doing a revision total ankle, ORF of the medial malleolus with long screws. And just a second, my sharing's not working. Sorry, I'll go back. Anyway, I did ORF of the medial malleolus with long screws. I did the Salto XT revision, and that's her walking at a year.
Dave, I think you got lucky.
Yes, I think you're right. Right, and that's your motion.
Yeah, I mean, I think you got lucky. This person's had, prior to that revision total ankle, she had 4 operations on this ankle.
Yeah.
Is that right?
Right.
So, I mean, my take personally would be, go to the nail with a cage, autograft, and say your prayers that didn't get infected. But I mean, your next move after this would likely need to be a transtibial amputation because you're running out of soft tissue.
If it didn't work, we could still use the cage here.
You could, and I think your risk is similar.
No.
I think your risk with a cage is similar. I mean, you're putting a lot of metal into a prior infected bed, so if you're trying to obviously maintain motion, I think this is a good option. But the patient needs to be pretty on board with the potential aftermath. But it looks great.
All right, Brian, you want to talk to us a little bit about this case?
Sure. So this is a case that I did. This was probably about 6 or 7 years ago. It's a 32-year-old female. At the time I saw her, she had an agility total ankle replacement about 8 years prior to seeing me. So approximately, do the math, 24 years of age, which that's a topic of a different discussion. She said that her ankle never really felt right, just had constant pain, all the way up to 10 out of 10 on VAS scale, years of swelling, treated non-op with braces, MAFO, NSAIDs, and now was being managed by a pain management specialist on fentanyl. And most recently, and she had obviously difficulties with activities of daily living, and her operative surgeon subsequently retired and wanted to entertain revision surgery to help her give her a better lifestyle.
So wait a second, let me just interject. So this is a 32-year-old who is now 8 years out from an ankle replacement?
Correct.
Okay.
Yep. Gets better. So in terms of her past medical history, she had a history of leukemia that was treated with chemo, and what I can gather from her, she was told that she had avascular necrosis in multiple joints around her body, and it included both of her ankles. I didn't have any preoperative x-rays of or imaging of which the agility was done on, but I had this image in my head, like on the top right, where she likely had a diffuse amount of avascular necrosis. On exam, she had well-healed incisions, both anterior and laterally, which was consistent with the agility implant. A lot of swelling, really no range of motion, both the dorsiflexion and plantar flexion. She had a rigid hindfoot with a pretty significant hindfoot valgus and planus deformity with tenderness laterally.
Now, I don't think like AVN, or at least some areas of AVN, are complete contraindications to total ankle.
No, I agree, but just the way that she was talking to me, it sounded to be more diffuse as opposed to an isolated AVN that could be, for instance, resected with with your cuts for an implant. So these are the APM mortise views that she came to me, that I got up upon presentation. The tibial component looks overall well fixed, maybe a little osteolysis laterally. There's obviously a significant amount of hindfoot valgus with subfibular impingement. As far as the talar component, you can see it's fairly not congruent. And then once you look at your lateral x-ray, it's kind of the meat and potatoes of the case. And you can see here that she had subsequent collapse of the talar body, and that talar component is essentially sitting on the calcaneus. The tibial component's in a little bit of extension, I'd say about 20 degrees or so. And as far as her talar head, it looks like there's some viable bone left at the present time. Next.
What's all that cystic change we're seeing there, Brian?
Where are you talking about, in the distal tibia?
No, it looks like it's at the navicular, maybe the cuboid. You just got these kind of lytic punched out areas.
I think that's probably projectional on my side. It didn't, I don't see that, but then obviously, to answer that question, that, it's necessary to get a CAT scan to look into that. That's obviously our first step here. Number one, to see if there's any other things going on, like you said, in the navicular potentially, but also to just make sure that there's enough, what bone stock you're actually working with. And the big question you need to ask yourself is whether or not this is, if a revision is an option in this case. So these are some slices of her CAT scan, primarily showing that the tibial component's well fused. The talus is essentially resting on the calcaneus, and few cuts show that the talar head, the residual talar head, is overall looks okay, both on those sagittals and axial views. And after talking to her about the different options, whether fusion, revision, limb lengthening, et cetera, BKA, she wanted to go on with a fusion. So when we talk about fusions in this setting, obviously the implant needs to come out, and you're going to be left with a pretty significant void. And traditionally, treatments of this sort are treated with bulk allograft, structural allograft, mostly femoral head. And unfortunately, despite advances in our technology and our techniques, complication rates remain high. There's a very high non-union rate reported in many papers, up near 50%. Luckily, a lot of these non-unions. Yeah.
Justin and Dan, are either of you guys or any of you guys using bulk allografts for your fusions?
No.
I'm not either. Nope. Justin, Dan,
I haven't.
you have or you have not been?
I have not.
Okay, keep going, Brian.
Yep. So, a number of these tend to be asymptomatic non-union pseudoarthrosis, which obviously is in the patient's favor, but unfortunately, a lot of them can go on to need subsequent transtibial amputation. We recently did a study at our institution looking at about 22 bulk femoral head allograft TTC fusions. Overall satisfaction rate was positive, 73%. I'd say for this type of procedure is fairly good. And you see here we had a pretty good improvement in terms of the FAM scores and VAS scores. Our non-union rate was fairly consistent with the literature. Again, a lot of these were asymptomatic, treated with braces, double upright brace, and so forth. And of course, a few of them needed to go on to some form of revision surgery. Luckily, none of them went on to need amputation.
It's interesting that 73% of them were satisfied, but 41% of them didn't fuse.
Yeah, and a lot of these, like I said, they go into non-union. And they're stable. So this is just a case of mine that I did a bulk femoral head allograft a few years back. She had complete talar body collapse. I did a bulk allograft reconstruction, and unfortunately, despite protecting her weight bearing for a period of time, that bulk allograft went to dissolve and obviously lead to hardware failure. And this patient, again, is not this case that I'm referring to, but just to show that the bulk allograft is not the messiah. And again, as far as other alternative treatment options, you can do a tibial calcaneal fusion, but that does lead to acute limb shortening, and especially in a young female, she's likely not going to tolerate that too well. Same reason, bone transport with a Lizaroff frame. Obviously, that takes a significant amount of time, and a lot of people don't like a frame, in particular, a young female. And then amputation being the end all be all, if the reconstruction efforts aren't successful. So, bottom line is that large osseous defects around the foot and ankle remain a pretty significant challenge. And that brings us back to our case. So, that's very nice. There you go. So, as far as the other options in the 21st century, as Dave is alluding to, is, luckily we have 3D printing on our side these days. Next. So there's a couple different companies out there that do these 3D printed implants, Additive Orthopedics being one of them, another one, 4Web. This was an earlier case that I did when 4Web was the only one around. And basically what you do is with your CT scan, you meet with an engineer and you discuss your design, the design process of this cage. And the nice thing about 3D printed cages, or any implant for that matter, is that the designs are endless. So you get your initial scanned anatomy. In this case, she had obviously significant hindfoot valgus. The calcaneus was lateralized. I wanted to shift that more medial and correct the pitch. So that is taken into account of where the foot's going to be positioned once you do your resections. Next page. And then on the left here, this is my planned resection, and you can plan this down to the millimeter using bony landmarks and so forth. And then on the right here, you have your superimposed cage, its placement, and here I was planning on doing a retrograde nail.
Now, do you make sure that when you're getting these drawings made up for you, there are additional options like being able to put screws through that cage?
So that's an option now. That's something that I have got as I've gotten more savvy with these cages that I've designed in my implants. you know, the additive orthopedics, most recently, for instance, I had a discussion with their engineer where you can have these kind of divergent screws to either put into the tibia or calcaneus to hold the position, but I still think that you need some form of load sharing device, such as a nail. I wouldn't rely, you know, solely on those screws, but you can obviously design these cages to incorporate into the midfoot, you know, a residual tailor head, so for instance, and then also, like I said, the tibia and the calcaneus. So these are images of what the cage looks like in real life. This is not, again, the cage that I used in this case. I just didn't have the pictures to illustrate, but just want to give you the idea. So on the left side, you can see there's 3 of them, and usually you get one size that you design specifically, and then there's a nominal increase and decrease, usually on the order of about 10%, so you can account for any, you know, changes intraoperatively that you didn't necessarily anticipate, you know, whether it be leg lengths and so forth. And as you can see, the cage is pretty, you know, it's very strong with this truss system in this particular cage, but it has a lot of, you know, voids in there that you want to fuse. So you need a large amount of bone graft. So in these cases, when I use this type of cage, I tend to take bone graft from the femur, use the reamer irrigator aspirator system. You can get a significant amount of bone graft here, as you can see. And if you come up short, you can obviously fill it with some form of allograft or whatever biologics you may want.
So let me ask you on this. So why not, first of all, why not use, you're already drilling through the calcaneus and the tibia to put in the nail. Why not use the RIA system in the tibia? Or why not go retrograde in the femur? Why
I mean, you can. I have more recently gone more retrograde in the femur. You know, the biggest thing, I mean, it's like you pick your poison, whether or not you want some post-operative hip pain or post-operative knee pain, but I have gone just more to the femur. I personally would stay away from the tibia in particular because I wouldn't want to weaken those cortices. What's that?
I said the tibia is right there. It's convenient. I'm not saying I've done it. I'm just asking.
Yeah. It's obviously convenient, but obviously the most convenient is not necessarily the best of options. And if you weaken those cortices, for instance, if you ream too proximal, the nail stops a little short of that, you get a little bit of a stress riser. Now you're dealing with a periprosthetic fracture. So I tend to stay away from the tibia for that reason.
Justin, when you do RIA, is it antegrade like John does, or?
Yeah, I go retrograde just because that's what I'm most comfortable doing in like the setting of hip fracture. So it's easy for me and quick, and that's just when I have to do it. That's what I do.
Any other suggestions, Dan, in terms of graft or filling these cages, or you've even using RIA as well, or do you use any other biologics?
No, I mean, I think for this amount, I think the RIA is probably the best option in terms of biologics. I do sometimes add a biologic, especially if you know, a patient that's less healthy and you know, less convinced about the quality of their own bone.
Like, do you mix it with the RIA, or what do you do? Or do you just put it on the cage, or?
Yeah, mix it with whatever autologous bone graft I'm obtaining.
Okay.
Hey, Dave.
Yeah.
I just wanted to make a comment. I go retrograde when I do these. It's the first move I make when I begin to operate. The exposure's there. I make a small incision, either patellar splitting or one side or the other, but you make the pass, you close that, and you get right to the main portion of the operation.
I do agree. I think retrograde is easier now, especially if you have a bigger patient. You can avoid the, you know, the pannus of the hip when you're going antegrade. So, you know, nowadays I do go retrograde unless there's some reason that I can't, whether it be a total knee, so forth, that would preclude me from doing that.
Yeah.
So coming up on here, so this is an intraoperative picture, again, a different cage case, but again, just to give you the idea. So those sizers that I showed you before, there's 3 sizes that go along with it, and it's cored out centrally so you can ream safely without violating your final implant. So once you get your implant, and once you get your appropriate diameter reamed, put your final implant in, and that's what you see on the right with good bone-on-bone apposition. So here's back to our case that we had before. So as Dave, alluded to in prior talks, some things come up intraoperatively that you don't necessarily anticipate. And in here, after I was taking out the avascular talus, that talar head really was non-viable as well. And I had a decision to make intraoperatively what to do with that void. As David said before, some of these cages can be designed to have holes for screws and so forth. So I didn't have that option here because I didn't anticipate that being the case here. I decided to leave it be and develop, hope that it developed more of a pseudoarthrosis and to support her with an orthotic to give her motion. Because if I were to, for instance, put something there, I'd be back at square one in terms of putting in a bulk allograft femoral head that has a fairly high non-union rate, especially to metal.
So wait, you mean like what? Like putting graft in that defect?
Right, to try and get it, say a bulk allograft to fuse to the navicular and the cage, to maybe bridge it from anteriorly from the tibia to the navicular. But I just felt that had a high rate of failure, and I'd rather have a little bit extra motion than decreased motion with a high risk of failure.
Dan, are you concerned at all about that? The front of that cage? Because it's fusing to nothing, right?
Yeah, I mean, I think obviously that's lacking structural stability through that through the talonavicular joint, but I think allowing some motion there may be preferable anyways to doing to extending the fusion, and then if it's not well tolerated, it becomes unstable.
Like, would you
perhaps,
leave it empty? Would you leave it completely as an empty space? I mean, you could fill it with like gel foam or like something so that it wouldn't be just a nidus for infection.
Yeah, I suppose. I mean, if you had anticipated that wasn't there, I think you can build on kind of a smooth metal extension like a hemiarthroplasty to extend into the talonavicular joint. But I mean, in this case, I'm not sure that putting gel foam in there is going to make a huge difference.
My thoughts were as well as if for whatever reason she started obviously developing a significant amount of pain or developing any further deformity through the foot, then obviously this can be revisited through a revision procedure. So, but this is some time out, ways out, and this is actually a picture of this patient enjoying her flip-flops. And to kind of add on to the case, she did also have avascular necrosis on the contralateral side, but it was fairly isolated. We talked about fusion, but obviously, having a bilateral fusion is not a great option, especially for a young female. So she got a total ankle on the other side and has been doing fairly well, knowing that it will be a revision at some point. So bottom line is that these 3D printed implants, they have infinite shade options to help you with multiple types of problems. These are just some x-rays of different types of cages. They come in different shapes and sizes, whether or not it just replaces the distal tibia, or again, the entire distal aspect of the tibia into the calcaneus. You can develop in that central bottom one. Again, if you anticipate that talar head is going to be non-viable, you can design it to articulate with the navicular, for instance. And this one, for instance, had screw holes through the cage that you can lock in that midfoot to aid into fusion. So just a lot of arrows in your quiver to help tackle these difficult problems.
That's great.
Hey, Dave, there's a question from the crowd. With the bane of any surgeon's existence is infections, right? Especially when you start doing joint replacement. Do you guys find certain bacteria is more difficult to deal with than others? And the question specifically is in regards to Pseudomonas aeruginosa. Have you guys found that more difficult to treat than, say, staph, which is so common, or even strep that you'll see every now and then?
Joe?
Yeah, I think at first blush, I do find Pseudomonas a little bit more challenging to manage, and you need to be certainly more aggressive with it. Certainly easier than treating a staph infection, but again, it's recruiting other subspecialists to assist you with this, and routine and aggressive follow-up and communication with your patients critical to see if additional surgeries are required during the recovery period.
I mean, I don't know if I've come up with any new things that I do that try and prevent my infections. I do put vancomycin powder on the surgical site before I close the fascia. I don't know if that, I mean, that's not evidence-based, but I do that. You guys do anything else?
The only other thing that I started doing from time to time is that took it from the hip and knee literatures is to irrigate it with a betadine solution, which is has been gaining some favorability.
You do that in primaries.
Correct.
Okay. All right.
Depending on their risk factors.
73-year-old non-smoker, valgus incongruent, geniverum. All right. Undergoes a star total ankle. This is 2 years post-op. This was done by someone else. He also has like a Malerba sort of Z, like step cut osteotomy with some trabecular metal wedges in his calcaneus. Justin, what are your thoughts? Dan, what are your thoughts?
So, I would want to see kind of full length, leg x-rays, since you said that geniverum, try to figure out how big of an issue that was. Obviously, it looks like, the arthroplasty is unstable. It's non-congruent in valgus, starting to get some, looks like some lucency medially, possibly some cyst formation. It's hard the talus looks okay so far, but sometimes difficult to tell with the star.
So he has varus knees, no knee pain.
And so his main pain is where at this point?
Pinpoint pain in the medial gutter.
Yeah. So I think, I think it's obviously due to the incongruity of the implant and the wear of the talus component into the medial gutter. I think it's going to, require either revision with an additional hindfoot realignment. It seems like the initial wasn't adequate, possibly even addressing something above the implant at the supramalleolar level to deal with or to try to offset the varus at the knee. Versus
your feelings about like what implant you like. Would you revise it with this same implant?
No, I wouldn't revise it with with another star implant. I think I think you're going to remove that and change it to one of the newer fixed bearing models. And having had to remove the star, you're probably going to want something that allows you a flat cut talus option.
Yeah. So his medial pain, good motion, normal labs. It's not loose on CT. So I like the options you came up with. And I mean, really, he just has isolated pain in the medial gutter because through the mobile bearing, this talar component is shifted medially. He has a knee deformity. He has a hindfoot deformity. The prior surgeon did try to correct his hindfoot deformity, but he still has valgus. And so here's what I did. And you could argue that it's not good or whatever you want, but tell me what you think. Before he had some medial impingement with his mobile bearing, I gave him a fixed bearing, right? Which is, I think, what, essentially what you were talking about, Dan, that even if you hadn't corrected the mechanical alignment from the beginning, a fixed bearing would still have loaded probably asymmetrically, but it wouldn't have failed in that manner, right? You can see how when I go through a range of motion with his native implant in there on the left, you can see how the talus is shifting to the medial side. You see that? See how it shifts and like impinges? And then when I put in a fixed bearing, it doesn't. And so you could argue that this is a 73-year-old male who's already had a previous attempt and that this will fail too, right? Because the underlying deformity, like Dan, like you pointed out, is not being corrected. And that forces are now going to be transmitted to the implant bone interface. And that like you need to either do a supramalleolar osteotomy or revise the hindfoot and consider a total knee, because he's actually like that, right? And so I just think there's no right answer. It's just a balance of judgment and discussing things with the patient. Brian, do you have any like criticisms here?
I mean, I think he did the right thing by exchanging that to a more semi-constrained implant. I would, if he had a significant amount of varus up at the knee, you know, even in the absence of pain, you know, I would consider it to straighten out, because I think with long, you know, the longevity.
He's just like, hey, I just have some pain on the inside of my ankle. I don't want a knee replacement.
Right.
Yeah, but Dave, did you revise his hindfoot?
No.
Why not? Why'd you decide not to?
Because clinically it wasn't that bad. I think that what Dan was alluding to is the deformity is really mostly in the knee.
Mm-hmm.
Look, I mean, look at the angle that tibia is coming down.
Yeah.
And if, by the way, if he does get a knee replacement, this total ankle's perfect.
Right.
All right, Joe, let us know about this case.
Sure. So this is a 65-year-old male who was involved in a motorcycle accident about 20 years earlier, sustained a distal tibia fracture that was treated non-operatively and did in fact go on to heal. No pain at the leg. His past medical history is significant for insulin-dependent diabetes, well controlled with a hemoglobin A1C of 7. Social history is unremarkable. His complaint is ankle pain with weight bearing on a VAS of 8. So his exam, he's tender at the ankle, somewhat tender at the subtalar joint, but his ankle is his real pain generator. He's got a very overall limited range of motion of the ankle. Subtalar joint is decreased, but again, minimally painful on exam. So I obtained images. This is my first set of films. Do you want me to keep going, Dave?
Yeah, I mean,
Sure.
you know, obviously we see something there on the medial talus, and looks like he's had maybe he's had some, you know, that just like you said, his motor vehicle crash a long time ago.
Right. So went on to heal. His overall alignment is not horrible, but he's got this significant arthritis. So for myself, my additional workup I obtained a CT scan, and it really gave me a significant amount more of information on the coronal and sagittal images. You could really appreciate the joint space narrowing, the irregularity of the talus. On the lateral, you can see these geodes and this significant kind of a depression within the dome of the talus. So the diagnosis is osteoarthritis of the ankle and some degree of osteoarthritis of the subtalar joint. So my treatment goals were for this individual to have a painless range of motion of the ankle, and he just wanted to ride his motorcycle, getting ready to retire. So the treatment options non-operatively are pretty straightforward. Arthroscopy is only palliative, certainly not definitive and curative. We did talk about ankle and subtalar arthrodesis, but he opted for total ankle arthroplasty, and I elected to leave the subtalar joint alone. So I did a star on him. The surgery was uneventful. The patient did well, and I'm fairly conservative with these. This individual has maintained non-weight bearing, 2 in a splint and 4 in a cast for a 6-week block of time. At week 9, he admitted to a 2-week complaint of noticing a rash about his leg. So initial move.
That's like, that is an understatement.
Yeah, it looks like an immersion injury to me.
Yeah.
Right? I mean, that's the first thing I thought is this guy's got an immersion. It looks like an immersion injury, but I'm concerned significantly about an infection in this individual with diabetes. So my first move was go back to just the basics. No recent illness, no pain, no constitutional symptoms, and his sugar is normal. His incisions are well healed. There's no drainage, no fluctuance, and he has a normal painless range of motion of his ankle, and there's no crepitation. Radiographs I obtained normal. So the decision was made, do I put this man on oral steroids versus topical? I chose topical because of his diabetes. I didn't want to flare up his sugars. I ordered serology and got a bone scan on him, and then saw him back at week 10. Again, no pain.
Week 10, like a week later, not 10 weeks of the rash.
No, 1 week later.
Okay.
Dave and Joe, I'm just going to ask you guys if you don't mind wrapping it up in the next 20 seconds.
Yep. All right.
Okay.
Going.
So bottom line is serology is normal. My concern was that he was having an allergy or allergic reaction to his implants. I sent him to an allergist, and he was actually found to be positive on the undersurface of his star, but not on the articular surface. So before taking him to an ankle subtalar, I gave him an IM nail. I sent him back to the allergist. That was found to be negative on 3 passes. And I did an ankle subtalar arthrodesis with eventual implant removal. The man's retired in Florida.
Awesome.
Doing well.
Awesome.
Well,
Thank
you guys, Dave, thanks for an awesome session on the total ankle revision and salvage. All the panelists, thank you so much for participating tonight. And thanks to Additive Orthopedics for sponsoring this session. We'll be back in a few moments on management of syndesmotic injuries.
Thanks for having us.
Thanks for
Thank
having
you.
us. Good
Thank
night.
you.
Good job, Dave.